Okay, in the spirit of keeping us on time, I'm going to get started. So welcome back, everybody. I hope you had a chance to see some posters and have some nice discussions. So as some of you know, just before Helene Langevin was recruited to serve as the Osher director back in 2012, one of our deans at the Harvard Medical School, David Galan, had this brilliant idea of transforming a more centralized structure at the time, the Osher Center, into a center without walls. And the premise behind this shift to a kind of a virtual institute was to decentralize the program and help break down silos, not only between integrative and conventional medicine, but between multiple integrative medicine centers across the Harvard Medical School landscape that virtually had very little communication with each other. And the idea was that if we can bring this network a little bit more together, we can enhance a lot more collaboration and synergy. And to support this transition at the time, I began what was the first audit of all the integrative medicine research going on across the different institutes at the Harvard Medical School and in the Boston area. And to my surprise, there was a great deal of things going on that I didn't even know about, and I had been here for more than 10 years at the time. And some of these were even led by my close colleagues. So as Helene was onboarding, I started to share this sort of map of research that was going on, and she had the brilliant idea of creating a visual map of this collaboration. Along with what now sounds like a koan, which is, well, here's our map, one of our research maps. And the koan is, what would happen to a network or a community when it becomes aware of itself by mapping it and seeing where you fit into some larger constellation. So to help manage this, this idea, this data, and create a virtual map or an integrative map, which you can see, Helene solicited the help of one of her colleagues and a digital communication guru, David King, who's the founder and the CEO of Exaptive, Inc. And Dave and his team has done a remarkable job building not only our research map, which he's going to show you, but also a series of other maps, a clinical map and some other newer ones that he's going to demonstrate with you directly. If you haven't already done so, I encourage you to visit the Exaptive exhibit table in the lobby, where you get to play with our maps, but you'll also learn more about the company and the many ways that they foster within and between institution collaborations with these innovative ideas. So please join me in welcoming David King to talk about our maps.
Thanks for having me. You know, this is maybe the integrative medicine way of phrasing this. I'm an engineer by training, and in engineering we have this adage that says, if you measure it, it will improve, which sometimes is good and sometimes is bad. It depends what you measure. But this is sort of the birth of this idea, which is that Helene and Peter, they knew that there was this vibrant community of researchers, but they didn't, it wasn't really being measured in a way that everyone could rally around. And so there was an interest to create some maps, and this is actually a screenshot from the first one we made about 4 years ago. And once they looked at the map, they said, oh, look, this is even sort of, there's more people, there's more interactions than we even knew. Could we get the email addresses of all the people on that map, and why don't we invite them to all get together? And that was actually the birth of the first Integrative Medicine Forum, which I like to think about as kind of, you know, we live in a world now with social networks and virtual networks, but I like to think about this as a physical manifestation of a virtual network, which I think is a really powerful idea. So in the time since then, we've been working to evolve the way that we make these maps, present these maps, and increase the community that we can serve, increase the sort of breadth of the IM community through these maps. Here's an updated version of the research map, and it's sort of beautiful in its complexity, and it allows you to see, as Peter talked about bridging silos, it allows you to see how certain researchers, these are all based on publications, so published researchers, how certain researchers, through their co-authorship, are able to bridge different institutions. And certain hubs, like Ted Kapchuk right there, which many of you may know, they sort of stand out really beautifully on the map. It also allows you to drill into the specific publications and access those publications in PubMed so that you can actually read what it is that's being published. And then on the left, there's the Osher team has done a lot of work trying to curate the various modalities. And so you can filter in and just look at a small network of interest, or, for example, mind-body therapy, which are all the red nodes. And so you can go from looking at sort of a cohesive view of all of the different modalities to a very targeted one. And we don't want people to just connect to research. We want people to connect to people. So zooming into a particular person here, you can see that person has one co-author, and you can link out to the Harvard Catalyst page to get some more information about them. So this is a tool that excited a lot of researchers, but we also recognize that the research community was just one facet of the broader IM community. So a couple years later, the focus was on trying to create a similar set of tools for the clinician network. And that's what you're seeing here. And I'll point out a couple things. One, this is a smaller network, which you can just see right away. And that isn't because it necessarily involves a lot less people. That's because this network is built based on academic clinicians that meet some criteria for this map. It's based on them participating and providing their information in this network. So this map can only be as big as the participation of the academic clinicians. So that's a little bit of an appeal if to talk to the Osher Center and to investigate if you meet some of the criteria to be on this map. Please help us expand this. This one is sort of different because it breaks down the sub-institutions affiliated with a given institution, like Brigham and Women's Hospital. And you can see a particular clinician, and the different colors are the different modalities that they work in that particular institution. You can similarly filter over here on the left. So you'll sort of see there's a theme. We've tried to make these maps consistent in terms of the user interface. So if you learn how to use one, you can then apply that to using some of the others. And one thing I think is interesting here is you can get sort of very detailed in terms of the modalities that you're looking at. And that's the goal, is to help people not only understand the clinical space, but also help people connect to particular clinicians that are practicing in a particular area. So this sort of expands the IM community that's serviced, but there's another broader community as these forums have become more popular. And as the Osher Center has worked to really expand its center without walls, the sort of tentacles of that center have included more and more people from a greater diversity of backgrounds and areas. And so for this conference, we put together another map. And this is actually a map of all the conference attendees. When you filled out your Eventbrite information, in the small print, it said, we can use the information you provide in Eventbrite to do something like this. So this is, you guys are the physical manifestation of this network here. And this sort of starts with the Boston-centered nucleus. So these are all the Boston-based research organizations, and then there's lots of people that sort of one-off people that we put into this sort of other local group. And when you click on a particular person in the map, you can actually see their reason for attending and some of their expertise. And it's interesting to look through the various different reasons. Here's someone actually who got quite specific, talking about education, and particularly in the field of low back pain health. And here's somebody else who's doing a poster presentation. So it's really nice to see the sort of diversity of the people who are here and why they're here. And this is the nucleus, as I said. So we can expand out to look at the New England set of organizations. So getting a little bit broader in terms of looking at other universities, not just from Boston, but in the New England area. And then we can sort of zoom out to the next concentric circle, again, of national organizations, of which we have a few. And then the really exciting piece was also to bring in the sort of international circle. And so you can see South Korea and Canada and Italy. And we have this like really fantastic group of people from all over the world that are interested in this. I think that one of the important goals of maps like this is not just to make pretty pictures, but to really try and form important human connection. I am a technologist and I work with technology, but I don't think the role of technology is to automate scientific investigation or human intelligence or creativity. I think its role should be to augment human intelligence and scientific investigation. So we really hope that you will take these tools as something that can augment your own progress in this field, something that can augment your own participation in this conference. And we've set up a booth outside that, this is my colleague Shannon, and so you're welcome to use the tool out there, or you're welcome to use your laptop and go to this URL. We use this cognitive city analogy because I've always liked living in cities, and I feel like the power of a city is that it brings lots of people together in a tight space in a way that leads to network effects and new ideas. And I've always been excited that social networks should have the potential to generate ideas and not just advertising. And I think we don't need more social networks, but we desperately need cognitive networks and using our technology to build these virtual cognitive cities. If you look at some of these images over to the right, you'll see some unusual pictures of like printing presses made from wine presses and things like this. And that's because in the history of innovation, a lot of the big aha ideas have come from cross-disciplinary pollination. And Shannon can tell you all about some great examples. And what we hope is that through tools like this, you will make some connections that will help create some of those cross-pollination of ideas and aha moments in your own field and across fields. So thank you very much.
Thank you, Dave. That was really cool to see the evolution of these maps and, as you said, the potential of them for bringing us together. So our next segment is also meant to bring us together, but in a much more kind of old school kind of way. It's what we're calling a town hall. And this is an opportunity where we're going to bring the leadership of the Osher Center together up front, and we'd like to hear from you. And we're going to use Slido to do that, as well as traditional microphones. And what we're interested in is your feedback, your comments, your suggestions. What programs that we're trying to do, like this one, make sense to you and are meaningful? Are there some other ideas that we're not thinking about, or things we've done that really don't work for you? And what should we really elevate to bring to the fore of our community? Like I said, we'll be using Slido, and as we bring people to the microphone, if we can ask you to be really precise in your questions, to really generate a discussion, we would appreciate that so we can hear from more people. For this, I'd like to briefly introduce and invite up to the stage my Osher Center colleagues, friends, and co-leaders. So first is Dr. Donald Levy, our medical director at the Osher Clinical Center for Integrative Medicine at Brigham and Women's Hospital. He's also an instructor in medicine at HMS and one of the best physicians I've ever met. So Don, you want to come on out? Dr. Darshan Mehta, who's our educational director at the Osher Center, but he's also the medical director for the Benson and Henry Institute for Mind-Body Medicine at Mass General, and he too is also an instructor in medicine at the Harvard Medical School. And then we have Dr. Gloria Ye, who graciously has stepped into this transitional role now, working with me as the Associate Interim Research Director for the Osher Center. And she's also the director of the Integrative Medicine T32 Fellowship based at Harvard Medical School, and also an associate professor at the Harvard Medical School. And finally, Ms. Atra Nusrat, who's our Osher's program manager. And frankly, without Atra's creative leadership and her organizational skills and her tireless effort, along with her staff, none of us would be here today. But before fielding questions from you, and in sort of as a way of enhancing our network's awareness as well as its appreciation of itself, I wanted to do a brief shout out to a few of the members of our distributed network. So this is a reminder, if you want to send questions up electronically, go to Slido. And so the first shout out is to Mass General Hospital, and I'd like to congratulate Vitaly Napadot and Bruce Rosen and other members of the MGH Martinez Center for receiving a very large and a distinguished Center of Excellence grant from NCCIH. This is a really highly innovative project combining mindfulness training and vagal stimulation that's coordinated with respiration rate to change autonomic physiology. And they're looking at the impacts of this really innovative combination of therapies on neural, a lot of brain scanning, inflammatory, and clinical outcomes in migraine patients. And those of you interested in this, Vitaly will also be presenting some of the background to this work at our grand rounds in February. I also want to do a I also want to give a shout out to one of my colleagues and mentors, Dr. Lou Lipsitz, who's at Hebrew Senior Life, and he's the director of the Institute for Aging Research. This week, actually maybe even tonight, he's going to be awarded the 2018 Donald Kent Award, which is a very prestigious award in aging to acknowledge a remarkable lifetime achievement in the area of gerontology. So. And another shout out to Zev Schulman Olivier and his team at Cambridge Health Alliance's Center for Mindfulness and Compassion for organizing earlier this fall a really innovative and successful conference exploring the interface between technology and mindfulness. It was a very well attended and rich discussion. And this is really cool to me. I hope you think the same. I want to acknowledge the leaderships at the Harvard Medical School of two deans, Dean Hundert and Sal DAmico, to make it mandatory as of this fall for every single entering Harvard Medical School student to participate in a 6-session program in resiliency and mind-body skills. Not an elective, mandatory. Darshan Mehta, who's on the stage, Osher's educational director, was a real key force in making this happen. And he, along with Drs. Michelle Dossett, who I know is in the office, Dr. Denninger, and others, delivered the program. And this is a program that was based on a program that I think Elise Park had a lot to do with and was developed at the Benson Henry Institute. And who would have thunk that a few years ago that this would be a required course for Harvard Medical School students. So I hope that not only we benefit, but that others that follow our lead use this as a model. So to the deans. And then finally, a shout out to Beth Israel Deaconess Medical Center, and especially to Dr. Gloria Ye for getting a perfect score on the renewal of their T32 Integrative Medicine Research Training Fellowship grant, which is no small feat. And Gloria and her HMS faculty are really proud to continue what actually represents the very first and the longest running NIH training fellowship in integrative medicine. So I'm going to stop there, and I know there are many other successes, but I really wanted to make time for you guys to share your thoughts and to create a discussion here. But if you do have other ideas that you want to share with the community, any success stories or landmark events, please let us know. Jessica Kaufman, who we'll introduce later, our administrative guru, will collect these things, and we can disseminate them on our monthly blogs and put them on our network maps, and so that the network has a better understanding of who we are as a whole. Okay, so now the floor is yours, and maybe just to move away from the technology, we can start with an audience question. So again, the idea here is we'd love to hear your thoughts. What's working, what's not working, any things to bring to the community. And if you don't have anything from the audience, I'll see if I can find some things from the Slido field. And if we don't have anything there, maybe I can start with our panel. Okay, so here we go.
Nice. Oh, wow.
So I'm going to go, some of these have been upvoted. I guess the first question that that strikes my eye is, why do you think there's resistance to accepting the validity of integrative medicine interventions and a greater push for pharmacological approaches? And how do we help facilitate this paradigm shift? So I'll bring that to the panel to start with. Maybe Don, since you've been at this for longer, I'll just put you on the spot.
Why is there resistance? Western thought, Western medicine, tradition. I was discussing with some fellows the other day that there's now evidence that looking for the silver bullet in an herbal product might not be the right way to go, that there's a thing called the entourage effect, which is being spoken about a lot for medical marijuana, where there are 60 or 70 active ingredients, and maybe our approach to looking for the one that's the right one and call it the silver bullet and make it a pharmaceutical is not always the best way to treat human suffering and disease. So there's that whole philosophy and a shift that way that causes resistance when we're doing things that are, quote, messy, but maybe it is messy to take care of other people. So that's part of the answer there. I think it's gaining more and more acceptance as people also tend to accept a scientific look at what they're doing, at least a systematic look, because in the past people just said, some famous person wrote a book and said that's the way it's done, so we'll all do it that way. And there's less and less in that, and more people that are really smart looking at what we do and coming up with reasons why it might work and why we might pursue it. So there's a lot of good things going on now that I think are making integrative medicine a part of healthcare, the way it should be.
Yeah, Darshan?
Yeah, I would just say that one of the ways that we can continue to elevate our dialogue is to have elevated conversations, which requires all of us here, as well as the outside community, to be critical and be actively critical of the work that we do so that it really improves the quality of the work. So one forum that we've really tried to do that has been our grand rounds. And again, this is open to our community. We welcome all of you there. We would want to make it the best attended grand rounds held at Brigham and Women's Hospital and Harvard Medical School. So if we can have that as a goal between now and the next network forum, it would be quite an amazing feat.
That's great. This next question sort of folds into that, and I know that Darshan and Gloria, you do medical consultations, and Don as well, running our clinic. But many other physicians are not as fluent in referrals or knowledgeable about what resources are available or the evidence for or against them. And so the top question on this list is, how do we tell our physicians or get our physicians to refer their patients to integrative medicine therapies? So maybe Gloria, you can start and then we'll pass it on.
I mean, I think that surprisingly, so I practice at the Beth Israel Deaconess Medical Center in Healthcare Associates, which is the primary care clinic there. And there's actually, a lot of openness to integrative therapies. I think much of the barriers lie in just education, of the physicians in terms of the actual evidence that is out there that can back up some of the therapies that we provide. And then just really knowing the network and who to refer to and how. And so, a lot of the work is around communication, interprofessional communication, and education of our colleagues.
I would just say we're pretty lucky in the city to have pretty much every major medical center have a representation of some dimension of integrative therapies. So really, the biggest barrier is oftentimes just lack of knowledge. I think in general, there's been quite a dramatic shift in the past decade where people are definitely open to referring. I mean, most providers are open to referring to one of these centers. But I think Don and I were just commensurating the other day that there's still, even though we've been at our respective centers for a decade or so, people still don't know we exist.
Yeah,
I just
Atra,
want to say real,
please.
oh, sorry. Go ahead.
Well, I think this is also where our network maps actually come in handy, because you saw the clinical network map, and Dave King, I believe, is saying that we need participation to populate that. So anybody who is a clinician affiliated with an academic institution, we can engage with you and get you on the map, and I think it's part of our job to publicize that. So the more we interface with different clinics, both complementary and integrative and also conventional, I think that will help cross that bridge, basically. So I think that's useful to hear as well for me.
Yeah, and I would say that it's obvious to this group, but Don and I, we were part of a study at the Osher Center, and one of the visions of the founder of this Osher Center and who helped start the clinic, David Eisenberg, we all stand on his shoulders for the field of integrative medicine, said, what happens when you put these centers not out in the community, but embed them in a tertiary care hospital? Does that change their visibility? Does it change their credibility? Does it change the flow? And so in a study that we did at our clinic, we had over 1,500 consecutive patients describe how they got there, and about half of the patients, and you can correct me, Don, are coming from referrals within the hospital. So there's something to be said about that. But going back to Darshan's comment, we also are interested in asking what kind of communication do you have with your physician about integrative medicine? And many people still do not talk to their physician about their use of alternative therapies that may synergize with or potentially confound some of the treatments that are being recommended. And the number one reason that they report for not disclosing it is because the doctor never asked. And so I think there's some room in terms of education about making that part of the general discussion between the patient and the practitioner. Anyone from the audience want to be brave enough to step up and bring a human question? Yeah, please use the microphone. Thank you.
Hi, I'm a holistic practitioner, and my question is that can we also have a representation from the holistic CAM practitioner community sometimes in the form of a panel to help exchange information, education about the CAM practices from their mouth, from somebody who's trained in it, so that it can get to be more and more truly integrative? Thank you.
Yeah. So this is a question about how do we expand out into the community to other therapies that are not integrated within the hospital themselves. Do you want to say something about that, Atra? And then I have some comments as well.
Well, I think that's going to be a work in progress. At the moment, we are focused on the Harvard network. We felt we had to have some boundaries to actually create a product which we could use. I think at the moment we have a lot of people aggregated under the other category, which we know is, we would like to expand that at some point.
Yeah.
We're not there yet. I think we're going to have to work with you to figure out what's the next step from expanding beyond the Harvard network itself.
Yeah. But I will say a couple things and then pass it on to Darshan. One is that we've tried to make this a center without walls as well as without doors. This conference is at no cost, and it's accessible to anyone within or without the community. I think that's trying to create a place where people can get together. We also do the same with our grand rounds, and the grand rounds specifically is designed to bring people from the community together with people inside the network. And afterwards, we provide coffee and snacks for people to get to network and know each other and talk about those sorts of things. So there's more room to grow and expand our inclusiveness and touch on topics that are not as close to biomedicine as many of the practitioners are here, but those are some of our initial starts. And Darshan, do you want to add to that?
Just to piggyback on that, if you are, for example, if you are sharing the care of a patient with an academic clinician that is, especially if it's based in the Harvard system, and you think you have a good case to present, I would encourage you to contact Atra or one of us, because it can be one of those cases that we would sort of evaluate potentially to present at one of our grand rounds presentations. Again, to build critical dialogue, to build understanding across systems, and then to understand how do we advance the work from here. So.
Yeah, and one of our most provocative and interesting discussions, led by Patty, who's here, was on a case study of a patient within the hospital receiving Reiki therapy. And I think it created a really fascinating interdisciplinary discussion of things that are already happening, but not quite on the radar of everyone involved in the community. So I'm going to do one of these and then come back just to no, you can, a little standing exercise. But sort of connecting a little bit to the earlier part of this discussion, how do we deal with interpatient differences in the responses to alternative therapies? Almost this personalized or patient-centered approach. I think Catherine and Manoj really spoke to some of these genetic, potentially different responses. And there's even some interesting literature out there now saying that some people have very negative reactions to meditation, that there's no free lunch for everybody, and maybe there's some personalized difference between people that shouldn't be asked to sit still for a while. So I'm curious if maybe Gloria, since you do quite a bit on mind-body medicine, or Dawn, since you advise on a lot of lifestyle and supplementary things. Maybe we'll start with Dawn and then go to Gloria.
No, I'd yield.
Okay.
Yield.
To the senator from the right. No pun intended.
I was a primary care doc for 25 years, and when you sit with another human being across from you who is ill or wanting health care or prevention, there's a lot to take in to get to understand that person, and then you look at all the resources you have, and it could be randomized controlled trials, or what my teachers taught me, or what expert panels say, or what they can afford, and you kind of work out a plan. And I think as new tools come, it would be easier, because I'd love to know that why I shouldn't even start SAMI, we were talking about, on this person, because I already know something about their genome. They won't do well with it. The way it works now, and the way it's always worked for me, is we embark on a journey together, and I say, for your depression, it hasn't worked for you to take the various drugs that are out there. How about we try SAMI, and we'll do it for 6 weeks, and here's the dose, and here's how we'll keep track of it. And if you throw up for 3 days, it's probably not going to be a go. If you feel great in 2 weeks, we'll just continue to watch it. And if after 8 weeks nothing's happened, we just did a little trial. And I think that's going to be the way medicine goes. And the more information, I'd love to have a genomic printout when somebody walks in the door and can already narrow down the kinds of things. Or a lot of that also is gotten by sitting and talking to someone. I can learn in a few minutes, and I've learned from teachers of mine like Randy Paulson, who's out here. Meditation's not for everybody. I don't need any genome printout to know that. In fact, you look at a person's face and they go, "Are you kidding? If I sit still, I get more anxious." How about Tai Chi for you? Would you like to move and pay attention to your breathing? Well, that sounds better. And you work it through together to figure things out.
And I'd just like to annotate that, because I've watched Dawn in action, and some of this is clinical experience, but a lot of it is based on staying so up to date with all the literature. So if someone comes in with a balance problem and he might recommend Tai Chi, he doesn't just say, what do you think about this? He might pull out 2 or 3 papers and say, there's someone just like you, and there's some studies around this, and that sort of enhances the discussion and the uptake. So there's an intuitive clinical sense that's married with evidence.
I actually show them your book.
I pay him for that. But I know he's given me articles on supplements I've asked him about and things like that. So maybe, Gloria, do you want to add something to that?
I guess just to say that I really think that integrative medicine and mind-body medicine, it's no different from pharmaceuticals in terms of the discussion that we had. Like the one size does not fit all. Like, I don't know why is it that we ever thought that in our history in clinical trials that we there are always folks that do well and some folks that don't and some in the middle, and it's not a mistake that happens. And I think we're really this is the era of personalized medicine and precision medicine that's going to apply to all of us and all of these therapies. And I think we're just trying to figure this out now. It's and for the mind-body research that I do, it's we see the same thing. We see the same thing in our trials, that some folks are very drawn to the therapies and get a good response, and others that don't, just as Don was saying. And I think some of my interest going forward is to figure out how do we better target our therapies, emphasize certain things versus others within just the mind-body therapies to to personalize, this more and make it more individualized, and find out how we can, best help each individual person.
Yeah. And I think that's a little bit of what's so provocative about the discussion earlier about personalized medicine and genomics and epigenetic phenomena and behaviors, is that clinical trials are designed today to look at one specific outcome for the average person in that population. And there's value to that. If we really at a phase 3 trial where you have something and you want to know if it's generalizable across a lot of people, that's great. But there are a lot of questions that really don't fit into that paradigm. So I think the use of big data, the use of individual-based markers is really going to be this huge disruptive paradigm shift that I think will apply not just to medicine, to integrative medicine, but to medicine as a whole. So thank you for your patience. Yeah.
My pleasure. So I work in public policy, and I'm curious about how important it is for a profession to have professional licensure to be respected by the medical community.
You ready, Darshan? You look like you've got something.
So question, just to repeat, so the question is how important is it to have licensure?
Professional licensure for a particular profession, for a physician to feel comfortable referring somebody to that profession to seek services.
Yeah, I mean, obviously, all of us, as physicians here on the panel, it's sort of paramount to the work that we do to have professional licensure. I think my own personal sense is that fields continue to evolve, and standards of practice and scope of practice issues are still evolving in many disciplines, and especially in integrative therapies. Some are established, and I think are well established, and so those are actually quite easy to say that you should be seeing somebody who is a licensed professional in that specific domain, like acupuncture, massage therapy, chiropractic care. These are all have been, for a long time, have been established practice guidelines. But other fields don't have that, and I think there are certainly experts here in our audience who are at the forefront of developing those professional guidelines. So in yoga therapy, in Massachusetts specifically, naturopathic medicine, and others as well that don't have yet clear guidelines. And so it is important, I would say.
Well, let me just maybe expand on that, because I work with professions all across the country, and there are conversations both in this state and other states. So in Minnesota, for example, they have a safe harbor bill that they did many years ago, where we know they have the Mayo Clinic. And there's question about, because it gets when you talk about scope of practice, that's a whole conversation in and of itself, which gets very complex. And also the ability to be able to support a professional licensing board. So there's a lot of implications just beyond the profession's desire to, or lack of desire to. So thinking about the future of how integrative medicine going forward, and be able to do fair licensing laws, professional licensing laws, or safe harbor bills to be able to allow people to practice appropriately. So I think we're in a bit of a interesting shift.
Yeah.
And also working with the ACIH, they created the physician desk reference for integrative medicine, and I don't know how much that's used. So I don't know what goes in a physician's mind to decide whether a profession is a viable profession. Is it the research? Is it the professional licensure? Is it because it's in the physician's desk reference? Where does that evidence come from that somebody feels comfortable? Because I know my physician, if I talk to them about integrative medicine or what I do, I get blank stares and being like, well, why wouldn't you consider pharmaceuticals or this or that? I'm like, well, because I actually want to pursue something else before we go there. And so I get a lot of blank stares.
Yeah. Well, I think this question of credentialing is really key. For example, the acupuncture community has gone a long way, and now there's national accreditation and state accreditation, similarly chiropractics and things like that. Yoga is not as centralized, and things like Tai Chi are unwieldy. And I think there's a lot of debate within those communities. Who's to decide whether you're good enough or not good enough, and how do you decide that in such a pluralistic system? So I think those are rich debates, and thank you for bringing that question up.
Thank you.
Yeah,
I'm just
Don,
going to add that I think anybody practicing licensed, unlicensed, whatever you do, if you write a letter to a physician saying, I saw your patient today and I did the following, I'm impressed. I remember the first time I was ignorant, didn't know much about chiropractic, and a chiropractor wrote me a note saying, I looked at the MRI and I agree with the L5-S1, blah, 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 and I did the following, and I set up a course of 8 visits, and if that doesn't work, I would recommend that you send him to an orthopedic surgeon, and I was blown away. That's just exactly what I'm looking for. Someone's willing to tell me what they do, what they think. They have some of the data that we all share, like an x-ray, and they're being very professional about it, and admitting possibly after 8 visits, I won't get them better, and we'll do something else together. So you can always write, whatever you do, I don't care if you have a license or not. We all there's many licensed people I wouldn't send anybody to. I've met plenty over the years,
Yeah.
at least not after the first one that
I think
But-
it's, yeah,
but-
okay. No, sorry.
just that even when I was just doing primary care, there's a cardiologist that would always send me a note explaining his thinking or her thinking, and I was impressed. And there was other cardiologists I never heard from. So they're all licensed, they're all got, the right credential, but some are much more easy to work with, I think, and I think better clinicians. So
And I think a lot of these changes happen on a person-to-person relationship, and so how we all carry ourselves in the community really makes a big difference as to how these change happens. While there's big things happening at the top, a lot of things happen at that grassroots person-to-person connection. So there's one very easy, low-hanging one for ATRA here, which is can we make, do we have video meeting capability for integrative medicine grand rounds? Some people are across town and it's hard for them to attend and participate regularly. Video would be really helpful.
Yeah. Yes. We've actually had videos up since 2015, so we have a whole archive of videos. And as Peter said earlier, it's one thing to have the video, I think, but it's another thing to actually come in person. So if you can come, coming to the coffee hour and actually meeting each other, I think a lot of the people that have been doing that for a period of time find the value in that because there's continuity in the community then. There's one other thing I just wanted to say. So how many people would be interested in having it live streamed? Because we have contemplated that idea.
And how many people who said that would do that instead of coming in person?
Ooh.
So we don't want to lose you. Okay,
So we will look into that. Yeah, thank you.
great. Let's finish up with one last question from Dr. Liu.
You just mentioned about the person-to-person connections. So I have a suggestion that Osher maybe can help to organize some special events or grand round, not just only at the Brigham Women's Hospital, but all the other regional hospitals. And another suggestion is that maybe, for example, can connecting acupuncturists with pain specialists, conventional pain specialists together in the same room and have an event, or like a yoga practitioners and with mental health, the conventional physicians at the same room, so that can form some personal connections. That's just my 2 cents.
Great idea, great idea. So I think we're going to wrap up this section now, and thank you all for the rich discussion. So the dialogue should stay open. Please send us your feedback. We have some places on our website where you can send comments. ATRA will say something about the follow-up forms for feedback from this conference, but let's keep the discussion going. So before we move on to the medley, since ATRA is up on the stage, or maybe she can come up here, she has a few comments to share about the networking groups that are going to take place during lunch.
Okay. Hi, everyone. So this is the boring logistical bit. So now that we've had a chance to answer some of your questions, we hope you also join us for more focused, facilitated networking. Yeah, there we go. Perfect. Yeah, thank you. Networking groups over the lunch break. I'm going to give you a brief overview of what to expect. So after we finish the proceedings in here at about 12:30, you can grab your lunch from the ground floor, you can view the posters and network. Then if you want to join a group, these will be running in parallel from 1 to 2 p.m. You can take your lunch in with you into the networking rooms on the second floor, but please don't take your lunch back into the auditorium or into the Bray Lecture Theatre, which is on the first floor. As Peter said, we'll get charged for it. The details and locations for each group are in your program brochure, along with the venue maps, but I'll give you a little bit more detail because it's a bit complicated to find them. And regarding the groups, we've chosen 4 topic areas based on the range of interest we received throughout our registration process since the beginning of the year. So thank you, everyone, because you've actually helped us shape which groups we actually chose. We couldn't respond to the whole range, but we've done our best to select what we hope will appeal to most of you. And of course, we're very fortunate to have excellent facilitators who have expertise in each of the respective networking group topics. So first, for the acupuncture group, we expect this will appeal to acupuncturists. I believe there were about 70 or so people registered before the storm hit, so we'll see how many there are now. This group will be led by Stephen Sinner, a faculty member of the New England School of Acupuncture at Massachusetts College of Pharmacy and Health Sciences, and Dr. Wei-Dong Liu, instructor in medicine at Harvard Medical School and lead oncology acupuncturist at the Zakim Center for Integrative Therapies at Dana-Farber Cancer Institute. Together, I'm sure they will provide an excellent environment for meaningful discussion. Steve is also coordinating an acupuncture gathering over lunch just prior to the facilitated networking group. So for those of you who are part of that group, please feel free to take your lunch to room 214, I believe it is, from 12:30 onwards if you wish. And then the networking group will start after that at 1 o'clock. And following from this morning's talk, some of you may have unanswered questions or new questions about genetics and epigenetics. And Doctors John Denninger and Catherine Hall will be happy to elaborate on the topics raised this morning and have cooked up some fun ways to help you learn more. Many of you expressed interest in learning how to communicate to others about integrative medicine. And we have a small army leading this group with Dr. Gloria Ye. We also have Dr. Michelle Dossett, Assistant Professor in Medicine at Benson Henry Institute for Mind-Body Medicine. And they will be accompanied by postdoctoral research fellows, Drs. Charles Coey and Daniel Hall. So their session will be framed around a spectrum of engagement and will focus on helping clinicians learn how to engage with integrative medicine in an academic setting. This group will follow more of a didactic format with Q&A to allow them to best share their knowledge, provide resources, and raise awareness and potential obstacles and opportunities. So this group will be in the Bray Lecture Theatre, which is on the first floor and can hold up to about 70 people. And last but definitely not least, we have Dr. Satbir Khalsa, Assistant Professor in Medicine at Harvard Medical School. He will be supporting meaningful discussions between delegates interested in topics related to mind-body medicine. Unfortunately, Dr. Khalsa's co-pilot, Dr. Leskovich, was unable to join us today because of the weather, but you will be in good hands with Dr. Khalsa. So, as you may have noticed, we're not the only ones in the conference center. There are 3 other groups. We're one of 3 groups in here. And as a result, we were a bit limited by the rooms we could use for the networking groups. So while you may have expressed a preference for your choice of networking group, what we have done is we've just made it first come, first served. So if you're particularly interested in one group or another, please go to that room at 1 o'clock. We've put signs up to help you find your way, but as I mentioned, it's a little bit difficult, so bear with me, almost done. For the session with Drs. Ye and Dossett for integrative medicine in the community, that's on the first floor. And I'm just telling you this now because you'll forget otherwise and you'll be asking us afterwards, which we will be happy to do, to answer. But if you go out of the auditorium and take the first set of staircases, and go right the way to the end, you go past the Elements Cafe on your right, there'll be some black doors at the end, go through those doors and take a left, and then you'll bear around to the Bray Lecture Theatre. So that's where Dr. Gloria Ye and Michelle Dossett, Charles Cohen, and Daniel Hall will be. And then all the others will take place on the second floor, and to get there, you have to take the other stairs on the far end, go up there or take the elevator, and you're basically going to work your way back to the auditorium along the balcony, the floor above, and it's going to wrap round. So the 3 rooms are just allocated over here. So I hope that helps, but again, feel free to ask us afterwards if you need to. So enjoy, and next week, before we enter the holiday season, I ask you to please keep an eye out for our post-event survey, where we'll be gauging interest in follow-up activities. So thank you, and I'll now hand you over to Gloria. Thank you.
So now we're going to shift to one of my favorite and fun parts of the forum. This is our very fast-paced oral medley presentation. So of the many research abstracts that we received, an internal Osher committee selected 15 to showcase in this session. You'll see 14 here on the list because the first one that's printed in your program, Dr. Lisbeth Baruta was not able to come. So we're going to start with Dr. Barry. And I hope that this session really gives you a sense of the breadth of the research going on in integrative medicine in our community. And it will entice you to go see all the posters during lunchtime. So each presenter will have precisely 1 minute to introduce themselves and summarize their poster. And this is all automatically set in PowerPoint, so I have nothing to do with it. It's just going to go on its own. It's going to keep us moving. So I ask that the audience just hold your applause until everybody has gone. And for the presenters, once you do your minute, you'll just sort of line up in the front here. We'll have a picture at the end. All right. So, whoop. All right, so here we go. Oops. Go back one. Okay. Terrific.
When do we start now? Good morning, everyone. My name is Michael Barry. So training in self-compassion, or the skill of being kind towards oneself in moments of suffering, shows promise for reducing disability and chronic low back pain. In particular, such training may improve the self-critical attitudes which often accompany this disorder, but the neurobiological bases of these improvements have not previously been explored. So to address this gap, my research group examined brain activity during self-criticism and self-reassurance before and after a brief 2-week self-compassion training, which was tailored towards chronic pain. So while undergoing fMRI scanning, patients were asked to imagine themselves in emotionally negative situations through either a self-critical, self-reassuring, or neutral lens. Following training, we observed changes to brain activity only during self-criticism, and these increases were associated with increases to activity in right dorsolateral prefrontal cortex, suggesting that brief self-compassion trainings for chronic pain may actually preferentially target self-criticism and its substrates in emotion regulatory brain regions. Thank you.
And one more. All right, so caregiving for veterans and military service member is stressful. So we delivered in this study a mind-body program by podcast to 34 female military caregivers from all over the nation, as you can see on the map. The program was adapted from the Benson Henry Institute's Smart 3RP program and included elements of psychoeducation, relaxation response practices, and appreciation practices. The program was composed of 12 to 15 minutes podcasts that were delivered daily for 28 days. And at endpoints, what we found was that participants exhibited medium to large decreases in perceived stress, as you can see on this graph, and also in anxiety and depressive symptoms. So now we hope at some point to be able to conduct a randomized controlled trial to confirm that.
Hi guys, my name is Sal DAmico. I'm a project coordinator at Boston Medical Center. I work with So Integrative Medical Group Visits, IMGVs, are 9 weekly 2.5-hour sessions that include didactic materials on topics relevant to participants with chronic pain and depression. So an RCT was conducted at 2 community health centers and 1 outpatient clinic. So this slide reports on the secondary analysis of adoption of stress management techniques, SMTs, by participants. So SMTs were categorized as adaptive, such as exercise, meditation, social connection. So non-adaptive SMTs were defined as alcohol use, smoking, and illicit drug use. So the intervention participants had increased the average number of adaptive SMTs compared with control group at week 9. And for individual adaptive SMTs, there was a statistically significant increase for exercise and meditation. However, there was no significant difference for non-adaptive SMTs. So in conclusion, the IMGV is a feasible intervention that, to increase participants' SMTs.
Hello. In a prior study, we demonstrated that patients with gastroesophageal reflux who were randomized to an integrative medicine consultation had significantly greater improvements in their symptoms compared to patients who received a standard primary care visit, regardless of the treatment received. In this study, we conducted a sub-study to determine the relationship between physician and patient behaviors in the visit and response to treatment. We analyzed 2-minute segments from the beginning, middle, and ends of study visit videos and rated them for a variety of different global impressions, such as how engaged, friendly, or relaxed the patient and physician were on a 1 to 9 scale, as well as the number or length of time that different nonverbal behaviors were engaged in, such as smiling, nodding, or gazing. We found that in integrative visits, the physician was more engaged, friendly, and relaxed, and smiled more compared to standard visits. And interestingly, the combination of both physician and patient smiling at the end of visits was significantly associated with GERD symptom improvement. Thank you.
Hello. We integrated mindfulness and compassion training into primary care and mental health treatment to help primary care patients with making health-related behavior changes. In a comparative effectiveness RCT spanning 24 weeks, all patients created an action plan at week 7. We compared 8-week mindfulness training for primary care with a low-dose comparator, which represented standard of care with a mindfulness intro, had attention-matched research staff time with biweekly engagement phone calls. Compared with the LDC, participants randomized to MTPC initiated action plans more frequently with adjusted odds of 2.28. They also had improved in emotion regulation and interoceptive awareness with moderate to high effect sizes. Over 140 providers referred over 465 patients. Enrolled participants were 23% non-white, 38% on subsidized insurance, 30% earned less than $20K per year. Recently accepted for publication. Come see our poster number 40. Thanks to my team, CHA, the NIH, our patients, providers, and you.
Hello everyone, my name is Yeongju Kim. Post-traumatic stress disorder, PTSD, is prevalent even among general population and has been associated with elevated risk of cardiometabolic dysregulation and multiple chronic disease. To understand the potentially modifiable behavioral pathway, we examined whether PTSD actually alters the behavior of dietary intake among more than 50,000 women in the United States. Our longitudinal analysis with the linear mixed effects spline model showed that compared with the healthy women, those who developed PTSD during the follow-up tended to have more unfavorable, unhealthful trajectory of dietary change measured by alternative health index and total flavonoid intake after the PTSD onset. Our findings suggest that effective behavioral modification strategies may need to be incorporated into the clinical and public health practices for individuals living with PTSD. Thank you.
We thank the Osher Institute for this opportunity. The aim of this study was to compare and investigate the modulation effect of Tai Chi Baduan and second on patients with knee OA. We found that all exercise can decrease pain symptoms and increase PD-1 syndrome level and immune response marker. We also found that all exercises can decrease functional connectivity between DLPFC, a key region of attention control, with the supplementary motor area. The connectivity change can correlate with the corresponding pain and PD-1 level. Finally, we found all exercises can increase gray matter volume in the SMA. There are DLPFC connectivity differences among 3 exercise groups. Finally, our results suggest that different exercises may share common and unique pathways for pain modulation. Thank you. Thanks for your attention.
Hi everyone, Yan Ma, first year T32 fellow. Our study evaluated long and short-term Tai Chi training effect on lower limb muscle co-contraction during walking under normal and dural task conditions. Specifically, we used surface EMG to measure muscle activity of the anterior tibialis and gastrocnemius. For long-term effect, compared to age-gender-matched Tai Chi naive adults, the Tai Chi expert has significantly lower muscle co-contraction under both single and dural task conditions. Longitudinally, after 6 months, we found a trend toward lower co-contraction in Tai Chi group compared to usual care control group. Although the difference was not significant, we believe that improved neuromuscular coordination of the lower limbs may contribute to Tai Chi's positive effect on gait and balance. If you are interested, please come to poster 23 for more details. Thank you.
Hi, everyone. The title of my research is Effect of Duration and Amplitude on Passive Stretching in a rat carrageenan induced inflammation model, exploring the dose effect of stretching. Our goal was to compare the effect of stretching duration and amplitude in a passive stretching intervention. We hypothesized that passive stretching would have a dose-dependent effect in neutrophil count. In this model, rats were injected with carrageenan 1% and then passively stretched twice a day for 48 hours. And then we found that it reduced the number of neutrophil counts when rats were stretched for 10 minutes with an amplitude of 25%, or when they were stretched by 5 minutes with an amplitude of 35%. Our results suggest that stretching could be used as a complementary intervention for inflammation of the connective tissue. However, we need more study to explore the dose effect in a chronic stage or setting, as well as the effect on pro-inflammatory mediators. Thank you.
Hello, my name is Camilla Osipiuk, and my poster is about the relationship between posture and mood in breast cancer survivors with persistent post-surgical pain. Breast cancer survivors often suffer both physical and emotional side effects, including persistent pain, which has been linked to anxiety and depression. Some studies suggest there might be a relationship between physical posture and mood. And while mind-body therapies may target the intersection between physical and emotional symptoms, it's not known whether their psychological benefits are related to physical posture. As part of an observational study of Qigong for survivors with persistent pain, we evaluated the relationship between posture and depression. We used a 3D motion capture system to measure posture and a self-report scale to measure mood. Results suggest improvement in depression and a trend toward more upright posture post-intervention. We also saw a positive correlation between changes in posture and changes in depression score. Come to poster 28 to learn more.
Hi, we conducted a pilot study to develop an intervention for parents of children with learning and attentional disabilities such as dyslexia and ADHD. It's a growing population that gets little attention, with 1 in 5 school children being affected. We adapted the existing Benson Henry Institute's resiliency program, doing in-depth qualitative research to identify and adapt the exercises to the needs of those parents, including difficulties getting a diagnosis, ongoing advocacy with IEPs, social isolation, and marital strain. We were proud that although only 50 people were recruited, we saw very significant effects post-treatment, comparing the intervention group to a waitlist control. We were also particularly excited that looking in the intervention group 3 months post-treatment, that these effects held. We are hoping to develop partnerships nationwide and conduct an implementation study. We leveraged the MGH telehealth video system. It kind of looks like a Brady Bunch when you're doing group treatments via telehealth, and so that allows us to continue our search nationally. Thank you.
Hi, I'm Travis Peterson. So selenium is an essential micronutrient that comes from the diet and is primarily used in the creation of selenoproteins, which are a small family of antioxidant proteins. Selenium recycling is very important for the creation and maintenance of selenoprotein levels when under selenium deficient conditions. When we have selenium deficient conditions or when selenoproteins are not working, we end up with various myopathies in both animals and humans. So in our study, we used selenium deficient conditions and loss of selenium recycling in a mouse model to see what the effects were. And we saw that slow twitch muscle was more impacted than fast twitch muscle. And this is important for further studying various myopathies in humans and understanding selenium's role in healthy muscle activity.
ApoE4 is a major genetic risk factor of Alzheimer's disease. However, 1/3 of dementia cases can be attributed to modifiable risk factors that we can impact in clinical care despite the gene expression. We embedded a health coach called a Brain Health Champion, who is specifically trained in evidence-based non-pharmacological interventions into routine care with patients diagnosed with cognitive decline. Through personalized goal settings and weekly phone calls, the BHC improved patient adherence to brain healthy recommendations over a 6-month intervention. As compared to the standard of care control group, there were statistically significant and clinically meaningful changes in self-reported physical activity, diet, cognitive activity, and quality of life. This is a low-cost, scalable intervention that can be personalized to each patient's individual risk profile. In the next phase of the study, we hope to investigate a larger patient population, including those at risk for cognitive decline, and include objective measures to track adherence through wearable devices and mobile health platforms. Thank you.
Hello, this is Güneş. How many of you check your email or social media to avoid stressful thoughts? This is called cognitive avoidance and is a gateway to stress and anxiety. Meditation, on the other hand, gives an opportunity to stop doing this and embrace those thoughts in a non-reactive way. In this study, we hypothesized that this non-reactivity during meditation provides a basis for extinction learning and adaptive regulation of one's emotions. To test this, we randomized participants into mindfulness or stress management training and scanned their brains using a 2-day extinction learning paradigm. In line with our hypotheses, mindfulness improved extinction learning through changes in hippocampal networks. Now, we know that the ability to remember that a stimulus is no longer threatening is a key mechanism through which mindfulness reduces stress. And this is why it is a better option than checking your Twitter account when you are stressed.
All right, that was wonderful. Thank you so much. Let's give everybody one last, another applause. You know what, you guys want to just line up over here and we'll just take a quick picture, yeah? Okay. So please go visit all the posters. Lots of exciting research going on. All right.
I hope you can feel your increasing awareness of the network. But there's amazing things going on all over our distributed campuses, and I'm always touched by this event. So before Gloria actually comes back up to the stage in a few minutes to announce the winners of this year's Best Abstract Awards, I want to take a few minutes of reminding you of some of the funding opportunities that are available through the Osher Center. And I'll be very brief, but we have 3 in particular that I want to mention. One is our core pilot research grants, and Olivia mentioned before that her pilot study was supported by this and it led to an NIH grant, and that can't make us any happier. So this is something we do annually. It's seed funding for projects in integrative medicine around the themes of mind, body, musculoskeletal health, and healthy aging. It's open to anyone within the HMS community at the instructor level above. It's open to people outside the community as long as they can find a partner to collaborate with as the PI. We give up to 4 grants a year that range between $25,000 and $33,000. So we have a $100,000 budget that we love to give away to promising ideas. And the RFA for this will be launched in January 15th, where you can send in a letter of intent to submit a grant. All this information is in great detail on our website, but I just want to remind you about that. We also have a postdoctoral fellowship. This is an innovative program that Helen thought about for cross-system integration between research groups, particularly at the postdoctoral level. So you have to assemble a faculty that is represented by people across different divisions or different specialties, which means at least a couple times a year these people start to talk to each other around the project of the student themselves. It's open to the Hills student program, so you have to be on the quad and part of the Integrated Life Sciences program, and we have 2 awards each year for up to $12,000, which includes some travel funds and things like that. And that admissions cycle is rolling and open, so please contact us if you have some interest in those areas. And then finally, we have this innovative short-term opportunity, and it's what we call our scholarly project, and it's a sponsored mentorship program that's open for students who are in the Harvard Medical School. And it's supported by a philanthropist that's asked us to think big. So not just how do we help certain people with a certain condition in a certain area, but she said, what if you step back and said, what's something disruptive and big you can think about that would change the health of Boston as a whole, and who would you bring to the table for that? And so we had a really nice first student who did some work on disparities and looking at what creates stress in different neighborhoods across Boston. And then we've decided we want to really get big, and we want to start to explore, can we really think about integrative medicine without thinking about the big picture, climate change, and how that's affecting our city and impacting us. So think globally, maybe act extremely locally. So we're looking for a really innovative and bright student in the medical school that wants to just start thinking of a project that can start to kindle thoughts around this very, very big idea. So with that, I want to invite Gloria back up to the stage to get a little exercise, and she's going to introduce, announce the winners of our posters.
Great, okay. So I have the distinct pleasure of announcing our poster abstract awards. So each year this decision is extremely difficult. You heard all the great work that's going on, and this year was no exception. So these 2 posters that won the award were chosen for their innovation, their rigor, and impact. And I think this year our 2 awards really highlight and beautifully showcase this research across this translational spectrum from the basic science to clinical implementation. So without saying too much more, I'm just going to go ahead and announce the winners. So I first want to congratulate and announce our second prize winner, which comes with a $250 cash prize, to Dennis Munoz Vergara from the Brigham and Women's Hospital. So his abstract entitled Effect of Passive Stretching Duration in a Rat Carrageenan-Induced Inflammation Model, Exploring the Dose Effect of Stretching. And then our first prize winner, which comes with a $500 cash prize, goes to Mi Nyok To from the Cambridge Health Alliance, and Risha Gowande, who gave the oral presentation, should come up as well. And their work was entitled Impacts of Mindfulness Training in Primary Care on Patient Self-Regulation and Accessibility. Congratulations. Congratulations to both of you and all of you, and to your research teams for the exemplary work. Yeah.
Thanks, Gloria. So a few quick announcements before we break for lunch. One of the things we've already mentioned is, and something we're very proud of, is our grand rounds. And we have a number of really exciting speakers coming up just to sort of whet your appetite. In December, these meet every first Tuesday, rain or snow, Whether it's the 3rd of July or not, we're really adamant about keeping this on schedule just so we create some consistency and structure. But in December, those of you who haven't heard Ted Kapchuk speak will really want to be here. He's going to give a talk on making placebos honest. Those of you who have heard him speak will really want to be here because it's going to be a really interesting presentation. We will cancel New Year's Day. That's a little off limits. But we also, as I mentioned, Vitaly Napadov from Mass General is going to be talking about his meditation crossed with Raven study, the respiratory-assisted vagal stimulation system. And he's an incredible scientist and speaker, and that'll be a really rich presentation. And we alternate every grand rounds from research to clinical. And so the next one after that is going to be a clinical grand rounds, and this is something we're trying to promote. One of our fellows is going to be talking about his research, bringing in a clinical case centered around his research. And this is an important area, which is the fear of recurrence in cancer and how you can potentially manage this real chronic anxiety, which is so prevalent using mind-body therapies. And that's going to be led by Daniel Hall. I also just wanted to alert, especially the acupuncturists in this community, to an event that the Osher Center has helped coordinate and sponsoring. This will be a nice trip up to Burlington, Vermont, University of Vermont. And what's interesting about this is that it's really translational. We have speakers who represent the powers at Blue Cross and Blue Shield in terms of making policy changes. We have really key speakers from the RAND Association, Patricia Herman, and from other policy think tanks, Lynn DeBar, and we also have researchers here talking about group visits and how we can reach underserved minority populations. So it's a real rich place where the best acupuncture research is being shown, but here we're trying to connect it to real-world issues and how we can make a difference. So if there's one conference to make in acupuncture and acupuncture research, this would be it. So finally, a couple comments. Since we're not going to convene together in this room again after lunch, I really want to take time now to thank all of our speakers again, all of our panelists for their generous time and contributions, and to thank Atra Nusrat, our program manager, and also Jessica Kaufman, who I'm going to embarrass and ask her to stand up. And come on. And without our support team's effort, this wouldn't have worked. And I can't tell you how happy I was to walk in this morning, nervous about how everything would go, and to see all the names on the seats and everything just in place. And those are the things that really make a big difference in a conference, in addition to the science. So thank you for that. And thank you, of course, to all our volunteers. And thank you, of course, to all of you for coming today and for contributing to being part of this network. Lunch is ready for you outside, and once you collect it, as Atra suggested, find your next steps. Some of you visit posters, some of you go to network groups, and we look forward to seeing you in about 2 years for our next one, and let's stay connected.